I'm Andrew Holden from Auckland Hospital in New Zealand, and today I'm going to discuss the final 5-year results from the IN.PACT AV Access randomised controlled trial, randomising the IN.PACT AV drug-coated balloon to plain balloon angioplasty in the management of stenotic disease in the AV access circuits. And these are my relevant disclosures. By way of background, we actually have a lot of population level data with regard to the management of patients with end-stage kidney disease, but it's not robust and it's not consistent. And for example, we don't have any gold standards on management of fistulas, creation of fistulas, and the maintenance of fistulas. Well, the IN.PACT AV Access IDE trial has provided a huge amount of evidence to help us with the management of stenotic disease in the AV access circuit, starting with the primary endpoint publication in the New England Journal of Medicine, which showed a statistically significant patency advantage for the drug-coated balloon over angioplasty, as we'll see. And there's been a raft of publications to follow at various time points, 12-month and 3-year time points. And we'll also see that there's been publications on economic analysis. So just to remind you of the IN.PACT AV Access IDE study, it was a prospective randomised multi-centre international trial of 330 patients randomised on a 1-to-1 basis to plain balloon angioplasty versus drug-coated balloon angioplasty with the IN.PACT AV balloon. Now I must mention that on both arms of the trial, optimum vessel preparation was performed with a high pressure balloon. The primary effectiveness endpoint was target lesion primary patency at 6 months, and we followed patency out to 3 years. Given the paclitaxel safety concerns that were raised, patients were then reconsented for additional vital status follow-up out to 5 years. So here are the key primary patency endpoints published in the New England Journal of Medicine. And you can see for the first time in a drug-coated balloon in AV access stenoses that we saw a statistically significant benefit for the drug-coated balloon. At 210 days, we saw a primary patency for the drug-coated balloon of 81.4% against the plain balloon primary patency of 59.0%. Statistically significant, not only for the target lesion, but as you can see and we'll see in subsequent follow-up, the entire access circuit patency is superior for the drug-coated balloon arm. So if we have a look at the Journal of Vascular Interventional Radiology publication at 12 months, again you can see a statistically significant patency advantage in the drug-coated balloon arm of 63.8% versus 43.6% in the plain balloon arm. One of the things we're really interested in is, would the drug-coated balloon be cost-effective? The basis of this is, yes, there may be some upfront cost for the use of the drug-coated balloon, but if it's associated with a lower frequency of reintervention, at some point in time we will see cost-effectiveness. We've published cost-effectiveness studies in both the US and the Japanese and Korean environments, and you can see that there is a time point, somewhere between 2 and 3 years, where IN.PACT AV becomes cost-effective. And it's likely that we'll see similar directional findings in other territories with cost-effectiveness. Now last year at Charing Cross we presented for the first time the long-term patency results of this trial at 36 months, and we were surprised and excited to see that the drug-coated balloon showed sustained patency benefit out to 3 years. A primary patency never been reported this high at 3 years of 43.1% compared to 28.6% in the control arm. And once again we saw the entire access circuit patency remaining significantly better. If we have a look at the Kaplan-Meier plots, you can see this point. And if you have a look at the left-sided primary patency curves, you can see that they tend to flatten out somewhere between 12 and 18 months. So the incidence of subsequent restenosis is quite low, and you can see that the patency advantage for the drug-coated balloon is preserved in both the target lesion and the entire access circuit. Now, one of the things early on that we noticed in this trial was the incidence of access circuit thrombosis. This is a catastrophic event, as we know, and it is associated with a significant patient mortality. At earlier time points, we'd seen a trend to a lower access circuit thrombosis for the drug-coated balloon, but by 3 years, this reached statistical significance, and this is a really important finding. We looked at some of the variables that might influence access circuit thrombosis. Patients had a higher risk if they'd had a higher pre-intervention rate, if they had a higher pre-procedural diameter stenosis, and for upper limb fistulas, but the most important driver of access circuit thrombosis was whether or not they had a drug-coated balloon. So we present for the first time at Charing Cross this year the long-term, that is 60-month outcomes of the trial. Now, as I mentioned previously, patients were initially consented to follow to 3 years for patency, but we wanted to follow these patients out to 5 years to look at their vital status. Obviously, in both arms of the trial, there were some withdrawals for various reasons, as you can see, but there was still a good number of participants that could be followed out to 5 years. And so for the first time, we can say that there is no mortality signal associated with this drug-coated device. We know that the mortality risk has largely gone away in the last year, which we're very grateful for. But you can see actually trending, there was even a lower mortality, a slightly lower mortality in the drug-coated balloon arm compared to the plain balloon arm. And you can see in both arms of the trial actually that the mortality was significantly lower than the predicted mortality based on a US database. Maybe that's a function of careful monitoring in patients participating in a trial. One of the questions I often get asked is why was this trial successful, and why have other trials such as the Lutonix AV IDE trial and the PAVE trial not been successful? And I think that we have to be honest about saying there are probably a number of contributors to this finding. So if we have a look at the differences in trials, we'll see that there were some differences in patient characteristics, differences in territories where patients were recruited in the trial. There are differences in trial design, and there were some differences in the procedure. I think the vessel preparation strategies in the IN.PACT AV trial really have been optimized. But probably the most important difference is actually the device, the excipient type, the drug type, and particularly the drug concentration and coating procedure. And it shows really that device selection is important if we're going to optimize results in AV access stenoses. So finally, let's go through some key points. The IN.PACT AV Access study is the only randomized pivotal trial in AV access circuit stenoses to demonstrate a consistent and sustained clinical benefit through to 36 months. The all-cause mortality remains the same out to 5 years. There is no mortality concern using the IN.PACT drug-coated balloon. The long-term durability of this study really shows that the IN.PACT drug-coated balloon really should be the standard of care in the maintenance of AV access circuit stenoses. Thanks very much for your attention.